because we are very late to the program and also live case pending in St. Anne's Hospital. So ask you if it's possible to finish your lunch and join us in the room. There is small change. We are going to start with Dr. Juan Miguel Fernandez with his presentation because he's obliged to leave us early. So please welcome him. He is going to share his experience with iVascular Neuro portfolio.
Okay. So do we have already the presentation? Yes. So I'm here to introduce you a new partner in the neuro treatment. Maybe as this is a so multidisciplinary meeting, many of you knows already iVascular. iVascular has been working for peripheral and cardio in the last 15 years, and now they are entering in the neuro. This is a full European company based in Barcelona. That for us is quite attractive because the characteristic of this company is that it's fully vertically integrated. That means that they own they have their own technology from the metal, plastic, and pharmacological. So they produce all the products. What open a big window for us in the neuro for developing new material. They get pellets of plastic, tubes of metal, and they develop their own products. So it's an opportunity for us to develop with them in some new concept in neuro. So I will share with you our experience with their portfolio in neuro. Some of them are classical concepts with some improvements, and some of them are new concepts I would like to share with you. Our opinion to assessing them is, as we don't have any evidence in which is the real better treatment, they should offer a big options for each doctor and for each patient. So we try to open a big portfolio of products, and we try to share with you with cases. This is the more easy way to present. So the first technique we can use with their products is the mechanical thrombectomy with the centrifuge. This is something that we all know. They have for that a full portfolio of microcatheters in 17, 21, and 27. All of them has been built in 165 centimeters to make them compatible with all their products and with other products too. And the 21 and 27, they are 2 in 150. And we asked them to produce something easy to deploy or to insert for the different tools we can use with them, mostly for the external drivers. They have this conical internal hub transition that makes very easy the transition in between the product and the microcatheter. The external driver is not very different to other ones. They create some integrative design that allows better integration with the thrombus, and we ask them to make them more visible. I saw today that many of you are working under general anesthetics. There, we in Barcelona, we still work a lot in local or under sedation. So we want to see better what we move on the patient, because patient sometimes is moving a lot. This is an example of the device. You see the device is quite visible. This is the distal placement of the microcatheters, and this is a double stent case where you see the marks that they are in an elliptic way placed to make them more visible, and this is a classical treatment. We have some studies, evidently now with the NDR development in Europe, we need to have studies for every single device we have. And this is a study made based on the Spanish register for thrombectomy. We have more than 5,000 cases included, and allows us to make a fast comparison in between the different devices. And what Intercept, that is the name of the external retriever, proves is that it's not inferior, is what we can always prove in thrombectomy, and in terms of safety has better registers, but we cannot really explain them, just to remark that. For the aspiration, they have developed a complete portfolio too. They have the 6, the 4, and they are bringing now the 5. What we ask them to get is a good navigation system with several transitions. a proper inner lumen, and specifically, as we are moving quite a lot over the combined technique, we ask them to make compatible the use of the whatever stent retriever with the device. So we ask them to have this kind of compromise in between good navigation and tip integrity and kinking resistance to be able to work with the stent retriever. So it's not only that we keep the integrity of the distal part of the catheter able to maintain the capacity of aspiration, but too is possible to make whatever kind of combination with the stent retriever, double stent retriever, Solumbra, a safe technique, whatever thing. So we are quite happy what they developed. This is classical cases. I mean, aspiration works in many cases. Even as I'm telling you, we are moving quite a lot over the combined because our feeling is that we get more sudden recanalizations. With aspiration, in particular cases, we have probably the same result in several passes, but we have more sudden recanalization with the combined, and we understand and we feel that it's better for the patient in terms of long-term results. But we still do quite a lot of aspiration, for sure. And again, a study made with it. This study has been very restrictive. We were analyzing only the capacity of the catheter itself, only helped by a microcatheter, and only by aspiration means, not combined technique was considered a violation of the protocol. And even though the result you see, the catheter is able to reach in more than 80% of the cases the treatment area without any help of anchoring. And in terms of first pass effect, the results are very good as much as in the clinical aspect. So this is 113 cases made in a monocentric hospital in Sevilla. It's the more active center in Spain, where they do more than 90% of the cases with only aspiration. So we went to them for that. And they had developed too the 4 friends. We were talking this morning about the complexity of the distal amiibo cases. We need a specific tools for it. This is clear. In my opinion, it's not only that we should better select the patients, but we should have better tools for that. It's not acceptable the number of complications we have. So this is the 155 effective length catheter that helps to reach very distal. It should be taken into account that with this length we need longer microcatheters to make them compatible. So this is the reason why they developed the INDEEP in 165 in all the cases. And we are still doing quite a lot of cases on distal. I absolutely agree. There are many cases that need our help to have a good outcome. This is a particular case, an old patient with a specific aphasia, very good MRS before the treatment, and we are trying in that case if we can to go only with aspiration, and you will see how the 4 French is able to navigate even with the support of 6 French proximally, is able to navigate only with a wire. Even then, we don't always do that, but when we are in a straight segment like this, we like to go with only the catheter is able, and we do only aspiration. And you see the result that the branch that was occluded was fully recanalized. So this is for the classical treatments. Now we move to the combined. The reason why we ask them to make this kind of distal access catheter that allows us to combine with the stent retriever without any risk of bending or destroying the distal part. And for instance, you see the stability of the catheter compared to other ones is much better. It's good for not only for the retrieval, it's good for the once you navigate, you keep better the anatomy. You don't move too much the anatomy of the vessel. That sometimes when you are quite distal, you can break some of the perforators. So we wanted something more stable on that. And this is a classical case with a carotid T, where in that cases, we went normally with combined, with a big stent retriever, a 6 mm by 50, combined with the 6 French in stroke, that is the aspiration catheter named. And there, you see the stent retriever is visible, quite visible with that gold points that has all along. And with the combined technique, we have quite a high number of first pass effect. And now we go for the new technology that this company is bringing to us. As you know, when we start doing thrombectomy, all of us, we were using balloons. We still believe, I'm still a believer of the to be useful to get a proximal flow arrest, specifically in terms of distal migration. So we have many problems with the catheters in terms of complications, in terms of navigation. It's very difficult. We are facing to very complex anatomy. So what we ask them to develop, instead of a proximal balloon guiding catheter, we ask them to create a distal access catheter with a balloon on the way up. So this is something that does not exist on the market. We are trying to, I will show you some cases how we work with it. The design is quite surprising for many people. As I told you, we work still in some awake patients. We were not happy to inflate a balloon. We wanted a distal flow arrest, but not as distal as to be in the subarachnoidal space. So we asked them to create a balloon with these characteristics. This is a proximal 6 French catheter, distal 5 French, with a balloon at 5 centimeters of the distal point. Why 5 centimeters? Because we wanted to inflate the balloon absolutely intracranially, but extradural. So it's intended to be inflated on the cavernous petrous segment. And with these 5 centimeters, we are able to reach to the point where the thrombus is to enhance the retrieval. By proximal flow arrest. So this is the design. So we are intended to be inflated in that segment below the ophthalmic artery. And with these 5 centimeters, you see the balloon is here inflated, and we can reach easily M1 distal, M2 proximal without any problems with these 5 centimeters. When you have a more proximal occlusion, you need to inflate a little bit below, and that will help us to get better support. You will see that the use of this device is not only to block the flow, to get a really distal flow arrest, but sometimes to enhance the support and allow a better navigation when we have very complex anatomies. This is a classical case. This is a M2 occlusion, where you will see how the device navigates. You see, this is a really distal access catheter navigating, and you will see now when it's going up here, this is the balloon coming up. And now once we are in place, close to the device, we will inflate the balloon. Balloon will start moving. When it stops, means that we are blocking the flow completely. And there we are able to do a Solumbra technique by retrieving completely the stem retriever. You see, once the balloon is inflated there, we have, it's very easy to navigate. As you are anchored with the balloon, it's very easy to approach your proximal long sheath. One of the ideas of this balloon was we wanted to have common access for whatever of the techniques we use. So when you want to use an aspiration, you are not happy to use a proximal big balloon, because that makes sometimes very complex the access. And to win time, we have fellows. Sometimes they are able to place for us the long sheath at the neck, and we can decide if we use aspiration pure or if we want to use a distal flow arrest with this catheter. So the access is common, is the same. And once you will see, once the balloon is inflated, we can retrieve the stem retriever. You see how the stem retriever is coming. We keep aspiration, so we are blocking the flow, allowing the retrieval of the thrombus, and allowing a complete flow arrest by aspirating very close to the thrombus with the flow arrest complete. And this is the results. One of the other use we have for it is, as I told you, is a very good tool when you have complex anatomies. The system navigates very good. It's like a really distal catheter. It's like whatever other aspiration catheter. And this kind of proximal complex access plus kinks makes a nightmare for us. You will see how easy it is for this device to navigate up, to stabilize the system. You will see now long sheath is very low. We were not able to count. You see the system is coming up there, and you will see now how the balloon crosses completely the curve without maintaining the anatomy. Does not disturb the anatomy, and with that support, we are able to bring up the long sheath and to do a thrombectomy in a safe condition, even in the more complex anatomies. And that's specifically good when you have problems to go up with your long sheath, you would like to get that proximal to the distal carotid to be able to retrieve completely the thrombus. And when you are not able with this system, you will see you can just approaching your long sheath here in the proximal common carotid, navigate your inedit system, and by inflating the balloon, you see we inflate the balloon there, and you see that you are able to bring up your long sheath because you are anchored completely. So it's not only to get a distal fluorescence, it's always to be able to help you on that complex navigation that you sometimes have. And with that support, we are able to do a complete thrombectomy without any problems. So this is the thing. Again, we have clinical data on that. We have proven that this device is good in protecting in distal migrations. We have less, this has been proven that we have less distal embolism once you are doing the thrombectomy, and that gives a better outcome that we were expecting. We have a standard reperfusion ratio with 83%, but in fact what is surprising is the better outcome we have, and this is the lecture we have of that, is that we have less complication and less distal migration of thrombus when we are using this distal flow arrest. That needs to be proven. So as a takeaway message, so you have a new partner for thrombectomy. Maybe no one of you has still seen these devices. They are being launched on the market. You will get them on your shield soon. And this is a quite complete ischemic stroke portfolio. As you told, you can use whatever of the techniques you can use with these devices. Some of them are classical in the use. One of them is the inedit. You need to think a little bit. This is a different concept. Remember, this is not a balloon guiding catheter, but it's a distal access catheter that has a balloon on the way. So this is a different tool that we have never had before. We are trying to find other uses, not only for stroke, and it can be used for many other things. We can discuss about that. All this portfolio has been supported by clinical studies. You can get access to them. They have all of them been published, and they demonstrate non-inferiority with the other techniques, and they have a safety profile. For instance, with inedit, we have had a lot of discussions with that. Why the inedit is less aggressive with the vessel when we do a proximal flow arrest is clear. We have a distal tip. Proximal tip is flexible, so when you inflate the balloon, you are anchored on the vessel, but you are not aggressing the wall. When you have a distal, a guiding catheter with balloon, you have a stiff system with a distal anchoring, and you can have, evidently, you can hit the distal part of the catheter against the wall of the artery and dissect. This is what we had before. Now we are quite happy with that. For instance, for the proximal occlusions, we are not using it. 058 lumen is the limitation we have. We don't have more than that because we pay the price of one French for that, but out of that is okay. So soon you will have that. And now you want, I'm here to answer whatever question you have.
Thank you, Dr. Fernandez. Are there any questions from the room?
Okay.
Thank you. I guess the industry will offers new devices nowadays and for the future. So at the end, we have to try them, and I still strongly believe this operator preferences, which we'll choose at the end. But of course, more bigger armamentarium for everyday practice can give you maybe better chance for success.
I think so. Thank you.
Thank you.